أنا هقدم محاضرة زميلنا الدكتور حمود الموسى، هو يعتذر عن حضور لظروف خارجة عن إرادته، فهي أمانة، فيسمح لي الدكتور عزيز أن أقدمها مثل ما حصلت عليها باللغة الإنجليزية. Okay. So the first slide shows how we diagnose, and we went through this yesterday in the afternoon and this morning. Detailed history and physical exam and supportive lab, either the basic lab or the advanced labs. But there's still sometimes you need to do a sophisticated test to reach the diagnosis. So using some advanced tests, as Dr. Barbush presented in his previous monoclonal antibodies by flow cytometry and Western blot, and that helped in diagnosing SCID like JAK3 and X-linked A gamma for PTK protein intracellular, and X-linked as very nicely presented by the previous speaker, Dr. Barbush, hyper IgM, and Wuskataldrich, you look for the WASP protein intracellular by WASP, and X-linked lymphoproliferative disease also. And the other functional assay used for the CGD test nowadays, the 1,2,3 dihydroamine titration test by flow cytometry also. But there's still a limitation even with using those advanced tests, that you need the reagent and the expert to interpret the result. Might fail to identify affected individuals if the mutation is hypomorphic mutations, for example. And there's other factors, the lab, the technicians, the human factors which play in those tests. Western blot is very intensive test and take few days to get the results. So where to go from there? Human Genome Project. There's in the last few years expanded the knowledge due to the advance in the molecular genetics, and that affected our field in primary immunodeficiency, where now about 200 genes were discovered and more to come. And also helps in the understanding of the pathophysiology of some diseases. So doing mutation analysis, DNA is stable. You can be repeated, is valid, and you get the same result most of the time. And there is quality control component of doing DNA. Molecular genetic studies, what's the aim of doing that? To get the definite diagnosis. It helps in diagnosing atypical cases. Sometimes it helps in getting genotype-phenotype correlation, like in famous example, Wuskataldrich syndrome. It can help in doing pre-implantation diagnosis. And also in genetic counseling, early perinatal diagnosis, and identify carriers. Also disease prevention, and if you are lucky, you could identify a novel gene which was not reported before. Okay, molecular genetic study defined. Okay. Yeah, there's a few slides are missing. Those are the cases, and does not show up here. So we'll skip. Okay, yeah, here it is. So, for example, there's few cases. It's 2 years old, presented with recurrent chest infection, eczema, thrombocytopenia, and low platelet volume. Of course, targeted gene study. By clinical, this goes clearly with Wuskataldrich syndrome, and molecular genetic confirmed the diagnosis. So that's a straightforward example. In regard to atypical cases, BID can present variably. It's always a diagnosis challenge, and extensive workup, even with extensive workup, you do not reach the definite diagnosis. This example of a 6-month-old with family history of sibling died at the age of 10 years with query immunodeficiency. The child presented to us with IgG of 1.5, A of less than deficient A, and IgM was normal or high. CD3, as you can see, is 1,300, and PHA was acceptable, 24,000, and hyper IgM panel was done and was normal, and no maternal cell engrafted. And so is it CVID or combined immunodeficiency? And that's always a challenge to decide. So he presented later at the age of 3 years, this time with significant clinical history, chronic diarrhea, failure to thrive, and severe infections. At this time, his flow cytometry showed severe decrease in CD3 and CD4, CD8. And his PHA response was just 5,721. So this end found to be is it RAG1, RAG2, Artemis, and it was a case of Artemis. So those patients can present with manifestation which presented more severe later in their life. The genotype-phenotype correlation Wiskett-Aldrich was the most studied and showed that there is a clear correlation comparing nonsense mutation with missense mutations. So what about pre-symptomatic identification of affected individuals and newborn screening? This is a 3-year-old girl. She was diagnosed to have familial hemophagocytic lymphohistiocytosis, and the panel, and she was planned for stem cell transplant. She had a matched sibling, and molecular genetic study can direct, especially in asymptomatic patients. This is a patient SCID, RAG1, family history of severe affected children, and status post stem cell transplant. Genetic counseling were done for the family, and pre-implantation genetic diagnosis was performed, and they had a normal child. So genetic testing helped in preventing newborn affected individuals. So perinatal diagnosis, this is another example of ADA SCID post-gene therapy. They had a twin pregnancy. Perinatal diagnosis were done, and was found that one of the twins were affected with ADA, and the other one was normal. So the cord was collected at birth and was used for the normal for the affected individual with ADA deficiency SCID. So molecular genetic studies, there's still also concern with the molecular genetic studies. It's the availability and the cost carried with doing those tests is usually research laboratories and commercial laboratories. So certified laboratories are rare for the definite diagnosis. There is a significance of nucleotide changes, polymorphisms, and it's intensive, and you need to go through lots of review to reach the diagnosis, and variable phenotype presentation and gene defect, and there's always the gene environment interactions later on. There is in primary immunodeficiency, this table shows the PID phenotype and the genetic defect. So T minus, B minus, and K positive, that could be different genes affected, RAG1, RAG2, Artemis, T minus, B minus, and K, ADA, and B positive SCID, common gamma chain, and the JAK3 autosomal recessive. And so this is just show you that different genes can cause one phenotype. So, and on the other hand, mutated genes, can be presented in different clinical phenotype. RAG1, RAG2, and Artemis can present in the full-blown severe combined immune deficiency. It can also present like Omen syndrome and also leaky SCID or combined immune deficiency or hyper IgM. Same with Wiskott-Aldrich syndrome, can present syndromic or X-linked thrombocytopenia, and also other immune deficiency. They can, the mutation itself can present in different phenotype clinical presentation. So Segner's sequencing, this is done for targeted multiple genes. It's laboratory and time consuming. Some genes are big and could be 8 or 12 exons, so it's insufficient and it's expensive. So, but now the next generation sequencing testing, where you can test at the same time many genes and short time and less cost. Whole genome sequencing and whole exome sequencing, where you the exomes only, and targeted panel next generation testing sequencing. So there's different technologies, and this table just, I'm not the expert, but it summarizes the different technologies used in different places, the methods, the length that the technology can read, base pairs, and the time run per, and the cost, and the advantage and disadvantage. The one we use at our center is Intron technology. We, Dr. Mahmoud Al-Musa and the team, this is the number of, this compared the published data in BID, and bear with me to go through this table. So this is the different technologies. There are 3 papers published so far in BID patients. The genes, the panel they looked at, the number is 173 in Stratford, and 170 and 179. And we have 162 in our panel, and it's expanding, as Mahmoud told me before recently. Total BID cases published using the different panels is listed there, and our panel 261 cases. The PID control, those are the one we know the underlying genetic defect, and we use them as positive control. So 13 in this group, and 41 and 18, and we did 122. The PID unsolved, here is 120, 26, and 15, and in our hands is 139. So the sensitivity, and this is comparing the, it's similar, the sensitivity it's not published, but here is 93, 83, and we had 96, so 117 out of the 122, which we know their molecular genetic was picked up by the panel we had. So, and we end up having a sensitivity of 96%. And we compare others like single nucleotides and needles, and at the end there is the comparison of the large deletions, because they are sometimes hard to pick up by those panels, and so the last is solved cases. We solved about 25% of the unsolved cases were found. Some published as up 40% at most solved. So even with the panel, you end up that you still have cases which you don't know what's the underlying genetic defect. And the last slide, the comparison of the cost. Yeah, this is another example where sometimes molecular genetics or the panel study we did surprise us with. Those are 6 and 7 years old girls. They had history of recurrent chest infection, chronic diarrhea, poor weight, and persistent CMV and EPV infection in the blood. Their CBC showed normal white blood cell count, and differential immunoglobulins were also within the normal range. by flow cytometry, CD3 and CD4 as mentioned here. It all were within the lowish side, but nothing significant. And they had 20% naive, but significantly their function response to PHA was 388 and the range to 4,000. There were no maternal. So this is a picture of a phenotype of kid combined immunodeficiency where they present later after the age of 2 years and with significant infection because there is CMV and EPV, and the function was poor. So the samples were run on the introns PID panel, and they had a ZAP 70 defect, which typically those patients present with CD8 very low, less than 50 cells, but it was an atypical presentation for those two girls. They went for stem cell transplant, and they are doing fairly good. Those are sibling. They are 8 and 7 years old. They had history of recurrent chest infections, and the 7 years old had more like also cellulitis, not only chest second. Their CBC were within normal limits, but they had low IgG and IgA and IgM. IgG was in the lowish side, not significantly low, but it was low. But over time, they lose their immunoglobulins, and they end up on IVIG. Their lymphocyte marker were fairly within the normal range, nothing like significant, and they had naive T cells. Their function to PHA was also within the normal range, and they were labeled to have hypogamma, and we start them on IVIG, and they are doing fairly well on IVIG. So their samples were run in the panel, and surprisingly, they had AKE2 deficiency, which is those patients present early in the first few months of life, and it is reticular dysgenesis, and they usually have neutropenia. They have sensory hearing loss, but they present late. Of course, like when you have something like this, you need to do more functional assay to find is this gene causing the defect or not. So the next step, as I learned that Western blot will be done to check for the protein and to make sure. And we communicate with others, and there's one case also treated right now in Boston with similar presentation, and AKE2 was found, but this was not published. So if you manage to publish it, that's like your controls. So those mutations interpretation, is it do you report it? Is it novel? Polymorphism, of course, you all know about the polymorphism issue and the significance, and you need to do functional assays always when you have something not typical. In general, if you work up of novel PID, the bias to go directly to the affected genes, and you look for the candidate genes. The non-bias, you do linkage analysis, and in our families, because of their branching and big families and more than affected, you have a chance to do linkage analysis for homozygosity mapping. And then you have the whole exome and whole genome sequencing. This is a patient we always talk about in our hospital, and Dr. Rand she has an abstract, but it's as you see, this is a big family. They have affected boys and girls, and clinically they had eczema, congenital thrombocytopenia, recurrent infection, CMV. So you have T cell dysfunction and thrombocytopenia and eczema, but these boys and girls are affected. So phenotypically, Wiskett-Ardagh syndrome, which is an X-linked, but in this family they have a autosomal recessive, and here whole exome sequencing was solved the family case, and WIP Wiskataldrich whip, which is a protein, interact with the WISP protein and can phenotypically mimic Wiskataldrich syndrome. And there is already reported one, and this is the second probably family. Thank you.